So welcome everyone to today's webinar, which is crucial in terms of elective recovery. My name is Stella Vig. I'm a consultant vascular surgeon based down at Croydon University Hospital, but also one of 2 national clinical directors for elective care. And as you are aware, we have published the recovery plan for elective care. And I think there are certain things that are absolutely fundamental. One is that we take care of our patients, and therefore there are recovery plans in terms of patients waiting. So patients waiting 104 weeks, waiting over a year, but actually bringing our appointments down to patients should be treated within the given timelines of 18 weeks. Of course, in there, we also have returns to targets for cancer treatments and for patients coming to outpatients. And there is huge investment at the moment, both in terms of the diagnostic capacity and our outpatient capacity, as well as building new theatres and enhancing the framework for that. But in that, we also need to support our staff. So today's webinar, which is tackling the elective backlog, looking at the perioperative and digital world, is crucial to us doing things differently. And we have to do things differently. I have 3 esteemed guests who are with me, and I would love them to introduce themselves if I may. So, Sunil, may I start with you?
Sure. Thank you, Stella. I'm Sunil Pudia. I'm a cardiac surgeon at Harefield Hospital, which is part of Royal Brompton and Harefield, and now part of the big Guy's and St. Thomas's NHS Foundation Trust. And I'm also a co-lead for cardiac surgery at Harefield and Brompton. And the reason why I'm here is that we have some experience of using some innovative digital solutions, and we'll talk about it in a bit.
Thank you very much, Sunil. Arash, may I ask you to introduce yourself?
Thank you very much, and a pleasure to be here. My name is Arash. I'm a paediatric doctor in West London, and I also work for Humour, a digital health company that specialises in remote patient monitoring for healthcare and clinical trials. The reason I'm here is because in conjunction with colleagues on the call at Humour, we're looking to build and deploy solutions to help address a number of the backlog issues, including both in elective care and in outpatients and acute care. So really looking forward to this conversation.
Arash, thank you very much indeed. Simon, may I ask you to introduce yourself?
Thank you, Stella. Yes, I'm Simon Tarry. I am the Managing Director of Smith & Nephew UK, Ireland and Nordics. And I also sit on the ABHI board, our MedTech Association industry group in the UK. So I hope I can bring an industry MedTech perspective, and also as Smith & Nephew is a large British MedTech, I hope I can bring a UK MedTech industry specific experience as well. So I'm looking forward to the conversation.
Simon, thank you very much indeed. So we're all aware that we have, 6.5 million patients waiting treatment at the moment, and nearly 2/3 of those are actually waiting for outpatient care. And I can tell you the story of Croydon, where for years we have tried to change the way we work in outpatients, to stop having paper records in clinics. And of course, as clinicians, we're very traditional. We do things the same way. COVID hit, and with 2 weeks, we went paperless in outpatients. Nobody has asked for paper notes again. We have involved digital solutions, so virtual clinics, telephone clinics, especially now in terms of the socioeconomic crisis that's hitting the country. If you are a patient on a 0-hour contract, the last thing you will want to do is to take a day off work and come to have a normal result given to you. And so patients are asking us to consider them at the center of everything we do. They're asking us to ask what matters to them rather than what is the matter to them. And therefore, the digital solutions around them are important. But we also need to be careful that we don't create health inequalities by the digital solutions we hold. So I think throughout these conversations, we will talk about tech because it's vitally important, but also talk about how we level up the playing field for individuals. In technology, what is crucial now is that we change our risk profile. So as clinicians, we do things differently. So I'm very much looking to Arash's talk in terms of virtual. If you have a patient who is in hospital post-surgery, why do we need to keep them in just to check that they're fine the next day? Why can't we have a virtual or digital solution that supports that? So this really is doing things differently. The Centre for Perioperative Care demonstrates that there is much mileage to gain for patients in terms of their pre-operative solution. Why do we all need to come up to hospital to have a pre-assessment done? Why can't we do that in a different way? So I'm going to stop there because I'm really looking forward to the conversations that are going to come into the room. Very much looking forward to the questions you're going to ask, which I hope are going to be challenging because that's where the conversation will come in. And if I may, I'm going to hand over to Sunil, really to look at, Sunil, the challenges that face clinicians and patients when it comes to elective care, but also your experience in technology in the cardiac surgery field. So Sunil, if I may hand over to you.
Sure. Thank you, Stella. I'll come to what we've done and how we came about that. But what Stella just mentioned is quite pertinent. Just last week, I was doing a consultation with a patient who's a plumber, and as Stella said, that it's difficult for people to take time off, especially if they're self-employed. And literally, he was in his van. He stopped in between his work in his van, and we did a consultation. And it was convenient for him, and that obviously was the way forward. And I think that's more and more that's what we are doing now. Coming back to what we were involved in, so again, if we go back to 2 years ago when COVID hit us, and all of a sudden in London we had 2 cardiac centers performing cardiac surgery from 7 centers. So you can see the burden of patients that we were facing with. But so we were obviously interested in treating the patients who are coming in through accident emergency, complaining of chest pain or or shortness of breath. We could treat with those. But what we started worrying about is those patients who are sitting at home, and how do we know that they are first safe and they're not deteriorating in their symptoms? Because obviously there are lots of patients on the waiting list, and all of a sudden we could not see them. They could not come into the hospital, and we did not have the enough workforce to start calling up all these patients individually, because everyone was deployed from cardiac surgery. Hospitals that did not do cardiac surgery, people are deployed to intensive care unit, to the wards to look after COVID patients. So we looked around, but we'd actually started thinking about this just before the pandemic. So we were in a good place about it. So we wanted to see how can we monitor our patients who are on a waiting list without us having to call them up or them calling us to see whether they are deteriorating, because you could have a patient who's fairly stable and is carrying on with their normalish lifestyle, but the minute they start deteriorating, so for us it would be chest pain, worsening chest pain, or increasing shortness of breath. How do we identify this patient? So we looked at a digital solution for this. So we found an app or a digital platform which had a mobile app on it, which we sent to patients, and they could. There was a QR code; they would scan onto it, and then there were a list of questions that they were asked about their symptoms, and they would then enter their symptom status of their symptom on a weekly basis. And if there was a change in their symptoms to the worse, obviously not to the better, but to the worse, then it would flag up to us on a platform that we had. And then one of our nurses would then call that particular patient and confirm that they have had worsening of symptoms or not. So we had to, all the surgical fields had to categorize their patients to P1 to P4, in fact P6. P1 meaning those patients who are in hospital need to have surgery, they can't go home. And then P2 are the ones who need to have a procedure within 4 weeks. So it was important for us to identify these patients who needed urgent attention. That is, within 4 weeks, we had to do perform the operation. So you can see what would happen is that patients who are in P3, P4, if they're getting worse, then they would start climbing up the ladder, as it were, into the hospital. And so we utilized a digital platform for that. So Harefield and Brompton, we started using this. And then we used to have a regular pan-London meeting to see what cardiac surgery was like across London, how we could help each other out. Patients could be moved from one hospital to another hospital. And we started talking about this. And now when we started coming into the recovery, and now we're talking about the elective, there are almost 1,000 patients waiting on the cardiac surgery waiting list just in London. So how do we prioritize these patients? Because clearly some patients can wait. It's not ideal, but they can wait because their condition is not as critical. But we need to pick up these patients who are deteriorating and need to have urgent surgery. So we are now rolling out a digital solution, again, an app-based solution that all the patients will have, and they can register their symptoms on the app. And this will be rolled out to the 7 centers in London. And and we'll be monitoring this. We recently acquired some funding from NHSE, and we in the process of rolling it out. So in Harefield, we'll be rolling it out. We're already using one, but the new platform is a little bit enhanced, so we'll use that. So this is to look at patients, to monitor them when they're sitting at home. They're on our elective waiting list to see how we prioritize those patients. The other thing that we were looking at is what do we do with these patients when they go home? And that will segue nicely to Arash, and he can take over from me. What do we do for these patients when they go home? Because again, we don't want them to come back to hospital. Ideally, yeah, they can come and we can look at their wounds. What's important for us? We need to look at their wounds. We need to see if what their heart rhythm is doing, because quite a lot of our patients go into atrial fibrillation. So we want to know whether they've reverted back to sinus rhythm or not. The only way to do that is to have an ECG. So now we've started looking at solutions, and there are some solutions out there which we are experimenting with, is to send them these devices, and they can tell us when the devices can monitor whether they're in sinus rhythm or they're in atrial fibrillation, and then we can make decision on the medication without them having to come to us. The other thing is the wounds. We have a digital solution for this. Again, we started working on this before the pandemic. Patients don't have to come to us. We see them normally at 6 weeks. That's our routine follow-up. So we don't want patients to wait up until 6 weeks before they come to see us. We ask them to upload their wound pictures onto an app, which we can then monitor on a weekly basis, and then we can see whether the wound is getting better or worse, if there's an issue. And if it is fine, then obviously we don't need to worry about that wound, and we just tell the patient not to worry about taking pictures on a weekly basis. And then there's some artificial intelligence built in behind this to see if the artificial intelligence can detect something from the pictures and can identify high-risk wounds, as it were, that us human beings with our eyes we can't see, but the artificial intelligence can pick up something that would say, if keep an eye on this particular wound, though it looks good now, but in a week's time there may be some problem. So either you start them on antibiotics or you put some special dressings on them. So that's where we are at the moment with the various digital solutions. There are loads of things I can talk to you about, but in view of time, I'll just I hope that just segues nicely for Arash.
Sunil, thank you very, very much. And thank you for the fantastic richness of questions that are coming in to the chat group. What we will do is we will ask questions at the end, because I think all three speakers will bring certain components, and I think it will add to the conversation at the end. If we look at outpatients, Sunil, as you've described, we look at outpatients, we now have to look at the entire pathway, which goes from before referral through into the referral part, diagnostics, and then right out to the other end in terms of patient-initiated follow-up and discharge. So the healthcare technology is going to be vital at every single point of contact with the patient. I'm also the chair for the Royal College of Surgeons of England Sustainability Committee, and therefore the green agenda is also vital. So Arash, if I may, I'm going to bring you into the conversation, and I'd love you to talk to us about the role of digital in supporting that efficient, sustainable, and actually patient-centered conversation, especially in terms of remote monitoring. And I'm very excited about the virtual ward.
Thanks, Stella. And it is a really exciting time. I think sometimes it's useful to put into context where the backlog problem started. Even before the pandemic, I think we were looking at over 4 million on the waiting list. We knew already there were workforce issues. We were already having situations every winter where acute care was impinging on delivery. And then COVID came and made all those problems so much worse. I've seen some of the estimates. I think in some places we're looking at potentially needing 14 million plus procedures. Some of the estimates are suggesting we need to double capacity. In my mind, it's very clear that that means we need to really rapidly modernize. We need to really rethink these pathways, and whatever interventions we introduce, they need to be quickly scaled. In my mind, I think digital is going to play an absolute important role, crucial role. I accept it's not all of the solution, but I do see it as absolutely necessary. And on your point about remote monitoring, I think actually it's a really good example of where we're using technologies that already have that evidence base that can help and support clinicians and patients. That's what we mean when we're talking about the value of digital in addressing these problems. So remote monitoring, as kind of Sunil alluded to, the number of advantages that it can bring, it does depend on kind of the quality of that deployment, but when it's done well, it gives clinicians essentially that complete picture of that patient's health throughout the entire journey. We can start introducing things like prehabilitation, which we might not previously have been able to do, but can now do so remotely. We can push the data that we're collecting to speed up that decision-making. We can highlight concerns much faster than the current cadence of in-person visits that we can probably offer our patients. So for me as a clinician, it's a really exciting time, and I can see so many applications of it, not just in elective pathways, but actually, as you alluded to at the beginning, in some of the outpatient backlog that I'm seeing in my day-to-day clinics. And so as a clinician, what I really want from a digital solution is something that's going to save me time and something that ensures that I'm maintaining the safety standards that I've always got in place. And I want the digital intervention for those patients to be enjoyable. I can see the question in the chat about, the concern about digital inequalities. I want a digital intervention that isn't going to make that worse, that can be used by a whole section of society, young and old, people who, for example, aren't normally digitally savvy, people who perhaps have had to get their first smartphone. I want that to be as accessible as possible. And I want this experience to be enjoyable for my patients, because I want them to engage with the plan that's in place, and I want them to follow the pathway. And I maintain that using any of these kind of apps, interventions, remote monitoring, it really should be no more difficult to put in your health data than it should be to put in your Friday night takeaway. And this is all well and good kind of talking about that, but I think there's a lot of work that needs to go in from technology companies such as ourselves, from the supply side, from the provider side, and to achieve kind of that desirable outcome, that patient-centered, evidence-based intervention. I think there's a few things that need to happen as part of this digital revolution. Firstly, I think evaluation has to be absolutely central to all the interventions that we do. I still think that's something that part of the haven't quite grasped. I see a lot of systematic reviews that are pooling together all the interventions, where what I think we need to be doing, and increasingly more people are doing this, is creating robust mixed methods evaluation of each specific intervention to see what's working, what's not, and work out how we maximize the experience for patient, clinician, and for the system. that does take time. It's a lot of effort, but I think we owe it to patients to put that work in, to analyze and publish those findings. It's something I'm particularly passionate about. It's why I got involved in digital health, for that opportunity out there. And I think we're at a really exciting time where we can apply the same academic rigor that we do in pharma into digital interventions. And actually, if you look at some of the wider evidence, when that's happened, you see cases where digital interventions are reducing clinical optimization times by 75%. They are halving mortality rates in some of the acute deployments. We're seeing reductions in length of stay. We're seeing patient adherence of up to 99% for some of these interventions. And I'm really optimistic that these are benefits that absolutely can be brought to the elective work if we can bring the right partners together. And that kind of brings me to my next point. I think collaboration is going to be really important. We need to start thinking about this almost like a digital health MDT, bringing in the expertise from, suppliers, from technology companies. Absolutely, patient groups need to be really involved in this and sharing their voice, and the provider organizations to work out what they need, what are the pathways for them. And then we need to share our successes and to learn from that feedback. So I think it's great that in one of the recent GIRF guidance documents, there's already showcasing some of the implementation of using wearable technology. And given the outcomes that we've seen in other therapy areas, I'm really hopeful that some of the work that's now starting in this space is going to replicate the huge benefits we've seen in COVID, in cardiovascular care, in diabetes. I think remote technology has a huge part to play. And I'm really looking forward to, in a few months, a year's time, where we can point to more and more of these case studies in these documents and show just across the range of conditions what remote monitoring has done and is doing for patients. And on a final note, and this is that kind of echoes what actually you said at the end, I do think this is something that, as clinicians, we probably need to approach with a little bit of humility. We absolutely must challenge and demand the evidence and scrutinize, but I do think we have to be ready to adapt. I look at a lot of my clinical practice and pathways, and truthfully, I do think lots of them are, yes, evidence-based, but they are the product of the history, the geography, and the politics of that local pathway. And I think we need to be open to the fact that there are other ways to do things. So post-operative reviews, if it's safe to do so, can we do them remotely if that's beneficial for the patients? In pediatrics, where I work, we're really keen now trying to move more and more things into kind of outpatient, into ambulation, into video calls, because it's really disruptive getting parents out of work, children out of school. I think if we look at what other industries have done, the benefits that they've brought through some of the remote working, some of these new technologies, and think about what it is we want to do to advocate for our patients and how they should really get to enjoy and experience healthcare, I think if we did that, we would probably agree a lot more about what the possibility could be with regards to remote patient monitoring. And the final thing I would say is that I think where this is going, and what I think is really exciting, is actually starting to build really holistic digital interventions. So interventions that aren't just solving one problem for a patient, but are actually able to guide patients through the various different journeys that they're going through. The backlog isn't, I don't think we should look at the backlog as a series of kind of cases to be done or clinic appointments to be done. It's a series of patients who've had problems they've waited on for a long time, and they need help and support with those problems. And I think the success we're going to get with this is going to be through digital solutions that can cater not just for one condition, but for a whole range of different clinical conditions, and supporting patients on that journey. And if we look to the way other technology works, that's exactly how it's designed. If I'm streaming a film, Netflix, Amazon Prime, whatever it is, I don't have separate accounts for comedy, for drama, for action. I have accounts for everything I need. And I think the future of remote monitoring is going to be exactly that. Single solutions catering for a whole range of patient conditions, whether it's their acute care, their outpatient needs, their elective surgery. And I think it's a really exciting time if we all collaborate together, start collecting that evidence, and start looking at how we scale some of these solutions.
Arash, thank you very, very much. And Hashim, I'm just going to your comment that digital health effectiveness needs a whole system approach, and the conversation, Bradley, that you bring into the conversation about prehabilitation, and there is absolutely no doubt. it's heartbreaking when you have a patient, you know, who's waited 18 months on the waiting list, and one of two outcomes happens. We then find out they've got blood pressure, hypertension, they need treatment, and then we send them back to primary care. Actually, our waiting list should be preparation lists, that we get patients ready for surgery if that's what we want them to do. But also the Centre for Perioperative Care is very clear that we can manage people's health in a different way. And we know that for upper GI surgery, patients who've actually lost weight, changed diets, actually no longer have symptoms from gallstones and therefore don't need treatment. So actually we do need to change healthcare absolutely on its head, manage our patients, but actually give them the solutions and involve them in the solutions that mean that they actually improve their health, even if they're sitting on a waiting list. So Arash, your points are very, very well made all the way through that conversation. If I may bring Simon in. So again, Arash, your conversation that we need to do this together, and the humility that we need to have as clinicians and the NHS, that we don't have all the answers. And Simon, you know, the healthcare technology, whether it's been the vaccinations or just driving different ways of delivering care, industry has been absolutely vital to those conversations. So I'm really looking forward to hearing how you think we should be collaborating in terms of delivering care as we go forward. Can't hear you, Simon.
There we are. Can you hear me now? Yes. Okay. Super. Sorry about that. Yeah. No. Thank you, Stella. And it's been a really interesting listen so far. And I think the first thing I'd say is I'm incredibly optimistic, which might sound unusual, but I'm very optimistic. If you were to listen to all of the noise that we hear, it does sound quite depressing. I know that, you know, the recent Times article, you know, suggested that we need a 50% increase in capacity and spelt out a lot of the size of the challenge. But equally, if I just look at orthopedics, for example, we saw that according to the British Orthopaedic Association statistics, that in March, the number of joint replacements done were back up to around 42,000 in March, as opposed to a normal place of about 48,000, and there was a significant reduction in people waiting longer than 2 years. So the first thing to say is I think there is collaboration taking place, and there is action taking place, and I think, you know, all credit to the NHS and to clinicians and to patients, and I hope to the industry as well, in starting work on this and making real progress. But there is a big problem, and as a medtech industry, I'm bound to say, and I think, and I believe, that we've got a real hidden gem. It's not often that, you know, people quite often talk about the pharma industry, but the medtech industry, particularly in the UK, is an incredible source of innovation and support, I think, to the NHS and to patients. And the role we can play, I think we started to demonstrate during the pandemic. And if you look all the way through the pandemic, medtech has played, I believe, a significant part, whether it be in diagnostics, whether it be, you know, in vaccine delivery, whether it be setting up the Nightingale wards, ventilators. You know, our own business at Smith & Nephew, we converted our factory in Hull to make ventilators. So I think medtech has played a significant part and continues, I hope, will continue to do that. And where can we make the difference? Well, we recognise the major issues around workforce, whether it be just, you know, numbers of people that we need in the NHS, but also the morale of the teams, which has been the most incredible 2 or so years. Capacity itself, physical capacity, and then of course the backlog and how we manage people. So I think the 4 areas that I think we can play a role as industry. First of all, speaking to NHS leaders and speaking to you know, partners in the medtech industry, it seems sensible to look at this. One way of looking at the problem is an end-to-end process. And in that end-to-end process, there are parts of that pathway where technology can play a specific role, I think, around productivity, around efficiency, around improving outcomes, and I think importantly, around patient safety. So I think there are roles that we can play with technology, and as an industry, there are, of course, whether it be imaging or whether it be, connectivity of patients. But it leads me on to the second point where I think we can play a big role, and that's around empowering patients and clinicians. Because if you look at that end-to-end pathway, and if you match that up with the scale of the problem, the issue that we're facing, it's clearly important that we provide data and information to clinicians and to patients that empower them. Allow clinicians to help prioritize their waiting lists, for example, to bring patients forward and backward, to allow clinicians, whether it be nursing or other paramedical staff or our doctors, to communicate with patients more effectively at home where they're safe, and to talk about prehab into the, educating patients. And I think we can help with that. Connecting data across systems, and allowing and partnering on the data from our devices to enable research, but to also allow, as I said, prioritization and control. Thirdly, I think one of the areas that we, the industry as a whole, medtech industry as a whole, is the most amazing innovator. And one of the greatest ways of powering up innovation is through urgent need. And so as we collaborate together, these issues are going to be the most amazing driver of innovation. And if we can collaborate on that, then I think almost anything is possible. We don't have all of the answers, but we have to remember that the industry as a whole, medtech industry, is a set of global commercial enterprises. And during the pandemic, some of those commercial enterprises went to zero. If you were a company that relied on elective hip replacement or elective knee replacement, your business went to zero. Our industry relies on our ability to serve patients, serve health systems, and be productive and efficient in that and provide value. And so we've never had a greater need to innovate and to collaborate, and to show what's possible. And then I think finally, on a day-to-day basis, our teams in the industry, we work hand in hand with clinicians. We provide education, we provide value, whether it's in cardiac, whether it's in orthopedics, whether it's in the laboratory. So as an industry, I think we can do an awful lot. For example, if I just give you one example, one of the main issues faced in surgery post-pandemic is that trainees have had less of an opportunity to train in their specialism. And the industry provides a significant amount of training around our devices to ensure safe and effective adoption of those devices. And we're increasingly working with new technologies like rods and cones, Google Glasses, for example, or Proximie, so that we can train clinicians remotely and increase the number of people we can collaborate and train around. We can work with the NHS supply chain around value so that we can get the best value and productivity to, for example, to the new surgical hubs. We can collaborate around capital build projects. So it's not just around innovation, which I think is critically important. And I think we're going to are seeing and will see some amazing innovation across the industry. But I think it's in practical, pragmatic, day-to-day areas as well that the industry can help, and in capital investment, and of course in data and research to ensure that everything is done properly and done safely. And we learn as much as possible as we go through that. So I think there are a number of ways industry can help. I hope our collaboration with Hume is going to be, one of those leading examples, and it is focusing on those, operational elements I've discussed, and the clinical collaboration as well. So yes, I think we've got a lot to do together.
Simon, thank you very, very much, and your messaging is absolutely on point. I'm going to stop now because I think it is vital that we go to questions, but I'm just going to stop and pause just to say thank you to everyone who's on the call. Many of you have been involved in providing COVID care, but actually almost straight afterwards providing care to patients who have been waiting, Arash, as you said, waiting for treatment and care. And I think part of our conversation in terms of digital, Simon, that you just discussed, was how do we take that huge number, which is 6.5 million, and break it down, because each of those numbers is an individual patient with an individual need. And actually, as clinicians, I cannot be responsible in my consultant vascular surgeon hat, responsible for the 6.5, but I am responsible for the 700 patients sitting under my care in my own trust. And so how do we start going back to the patient conversation? And I'm going to start there, if I may, and then I want to touch on the staff. So I'm just going to check a few names here. So Eleanor, thank you so much for the Fitter Better Solution Sooner Toolkit, which is the Royal College of Anaesthetists, which is a fantastic document and well worth the read. And I'm going to come down, I'm going to go right down to the very bottom and start there in terms of questions. So the first question, the sort of questions that came into the chat room were really about digital inequity and how do we ensure that health technology is available to all. But also that second question in terms of virtual monitoring. So, for example, the blood pressure monitor, how are we ensuring that we've got the technologies that we need for that? So may I ask you about the solutions for patients, how you think they will are being implemented, how they should be implemented, what should we be thinking of? Sunil?
Yes. Thank you. I've been following this, and if I may, I'll answer some of the questions as well. So, we were all concerned that there's going to be inequality of access, and especially with the elderly population. Most of our patients are in the elderly group. So I was just reading. Someone asked a question: how many smartphones are there in the world at the moment? There are 3 billion smartphones in the world. That means, every other person has a smartphone. And if you take away the children and all that, so, that number comes even smaller and smaller. So you'd be surprised that even the elderly people are quite comfortable using the smartphone, especially the basics. And the apps that we have been using are not that what word should I use? I shouldn't use labor intensive, but they're not that difficult to use. They're fairly straightforward, just tapping on some lines and submit. So it's not that difficult. And but I completely agree that we need to be mindful that this technology is accessible to everyone. The other question, Stella, if I may, there's some question which Nigel asked, which is quite pertinent because we've been working on this as well, where he's asked about PTSD. How is there a solution for this for patients undergoing cardiac, some sort of procedure? And he's mentioned triple bypass surgery. So before the pandemic, we were looking at a solution for this, and I think we may have a solution. What we did was we recorded our hospital pathway for all these patients in a 360 environment. So someone puts on a headset, even they don't have to come to the hospital to visit our hospital. So Harefield Hospital, there's a 360 video of the pathway the patient will follow from coming into hospital to the ward, to the theaters, to ITU, to HDU, and then to the ward and out again. And they can experience that. And the aim for this was to see if we can reduce, though we wanted to say reduce delirium, post-op delirium, but also to reduce PTSD as has been put there. And we, using the same technology, we have some patients who are on intensive care unit who have been there for a long time, and they long to go to home, to go and visit their home, or the loved ones want to come and visit them. So you can use again the 360 technology. The relatives are sitting at home, they are sitting in the ITU bed, and they can virtually visit their home, and person at home can virtually visit their loved one in the hospital. So this technology is there. We've tried to use it, and but obviously due to the pandemic, some of this has slowed down. But I mean, if you look around, there is technology out there, and as Arash and Simon have been mentioning, we just need to work with the patients, and we'll find some solutions.
Thank you. Simon, Arash, anything else to add to that?
If I may, I think the operative word here is about choice. We have to empower patients to have meaningful choice. I think if you have that mindset, it actually helps us go through some of the problems that have kind of been highlighted in the thread. So when it comes to the inequalities, particularly, elderly patients who we know are going to be using healthcare services a lot, we have to make sure that these interventions aren't something we force upon them. They're actually like a useful choice because it's convenient, it's easy. And that takes time. I think this is where anyone who's involved in building a digital intervention should be spending time and time again, iterating, building, designing, making it as user-friendly as possible. And then looking at that data and seeing how are people engaging with it. And I think if that hasn't happened, then I think we're not giving patients that full justice of the quality that they deserve. I think when it comes to the devices as well, again, the key thing is choice. We know that there are a number of different technologies that are available. So kind of at one end, even with remote monitoring, it's very possible to just have like a standalone device and then you input the data in manually. That may well work if patients already have a device or you're looking for the most, the cheapest cost-effective output. Might not be the most friendly or easy thing for the individual. So you might want to have like an integrated device. And actually, these are becoming more and more affordable. And I think any platform that's going to do remote monitoring needs to be able to cater to the wide library of devices that are out there. And then I think actually a final thing is, the marvel of technology never ceases to amaze me. If you think about what a smartphone is, it's a device that has, the computational power millions of times what we use to send people to the moon. And it's in our pockets. It's a gateway to all the knowledge that we've ever had. And we're seeing now that more and more technologies are using the different aspects of that technology to actually collect some of the vital signs directly. So things like respiratory rate, things like heart rates can now already be collected on a smartphone. And it may well be that that's the easiest thing for that particular patient because it means they don't have to carry another device. They don't have to have a wearable. That works for them. Whatever the answer is, it absolutely has to be about choice. We have to involve patients in these. We have to present them with the options and we have to give them meaningful choice in what they want their healthcare to look like. And I think if we do that, I don't know what the right answer is, but I'm sure we'll find the right answer.
Arash, thank you very, very much. If I may, I'm going to move on to supporting our staff. And Simon, you made a very important point that there is widespread, we know from individual practices, widespread inefficiency. I think it was Bradley talking about the difficulties with interoperability of different systems. As clinicians, we sit and we have to open up 4 or 5 different systems to do what we need to do. The Excel spreadsheets, we talk about fax machines sitting in outpatients, but we're all using Excel spreadsheets to track the data. And there is a conversation, how do we track data that is at high level, which gives you trends, but how do you track patients individually? So exactly as you described, Sunil, that the patients that need care faster do get it, but actually clinicians have access to the data that needs to be looked at. So we standardize, so they're getting it right first time, gives us data that allows us now to make very proactive decisions. But how do we start thinking about using big data that sits within hospitals? How do we start planning our list? How do you think that's going to fit? So Simon, may I go to you first?
Yeah, sure.
Because huge innovation so far.
Yeah, there's a couple of things of important points. The first one is that it's not, from an industry perspective, of course, there are challenges around sharing data, and they shouldn't be underestimated, and whether it be GDPR, protection, security of our data, whether it's the integrity specifically and more broadly of patient data, and sharing data and amongst hospital systems. So there are challenges, but I do think that the NHS has a very willing partner in medtech, and I think that there's also a willingness to start the discussion much more meaningfully around sharing of IP and data. And I think and I know that's a big challenge, but I suspect that the start point is very simple, basic research, so that we can look at patient-reported outcomes when new technologies are introduced. I think collaborate around, basic registry collection of data using methodology like the Humour platform that we're talking about here. But there are others. But it's that basic principle of collecting basic registry data, I think, is really important. Looking at ways of reducing variation of practice, so that we can, try to support, again, one example. If you look at wound care across the NHS, there's a huge variation in practice in wound care, and yet it can have a dramatic approach on the ability of a patient to go home early, or to be treated in the community and kept at home with their family. So there are some really basic areas that industry, I think, broadly can collaborate and provide value, and to start that journey together. And I think the industry is very, very, very keen to do that. So, so I think broadly, data is at the heart of providing value, and we should collaborate across that. As an industry, I think you'll find us a very willing partner, to do that. I suppose the other final point is that wherever possible, we should collaborate on trying to make as few options available as possible, because and the way to do that, I think, is to try and make them agnostic. And again, I know I'm sort of challenging myself there, which I'm thinking about as I talk, because again, it's a challenge for us as an industry to say, here's this platform and it's open. But I think wherever we can do that, I think it's a huge advantage. And again, we've tried to do that with the Humour platform. It is difficult, but I think it's really important, because then it can be applied in lots of different areas and disciplines. And you're not, the NHS staff aren't going, and I've got this system for this, and I've got this system for that, etc. So I think where possible, collaborate around the systems, bring together broad churches of partners to collaborate around a single system, and start simple and clear, and include, sharing of data for research.
Thank you, Simon. And one of the questions in the chat was, how does this link in with the NHS app? And I think the NHS app and My Plan Care are going to be pivotal in this. So, I can go into my NHS app and I can now order my medication, which now arrives on time because it's delivered to me. So my blood pressure is now under control. Whereas I can tell you 2 years ago, it wasn't, because actually it was hit and miss when I got to the GP to get my prescription. So simple things make people's lives much, much better. We know that there are areas that are doing things really well. So Peter, you asked the question in terms of prehabilitation. We know that prehabilitation is being trialed in certain areas. We know that list planning and actually scheduling is being, we've got areas that have the most unbelievable practice. The question is, how do we scale and adapt across there? So Peter, your particular question in terms of what is NHS England doing to ensure that prehabilitation is essentially widespread practice. Ramani, who is the NCD for perioperative care and anaesthetics, is actually managing that work stream and is doing exactly as the question you've asked, which is managing that process to make sure that it is BAU, business as usual, rather than one area saying, wonderful, please look at what we are doing. So my challenge to the three of you is knowing that there are areas of best practice, and knowing that there are these conversations of actually inequality in digital technology at the moment. How do we address that, and how do we scale and adapt? Arash, do you want to go first?
On the issue of inequality, I think we have to go back to the data and patient involvement, and that's something that has been a very big part of our journey, and certainly in all of the deployments that I've been involved with, a big part of what we do is monitor, actually on various grounds, what it is that's affecting digital inequality and actually how people are using it. I do think it's important to bear in mind, building on Sunil's point about the global state. In the UK, we have 55 million smartphones. And actually, I'm now seeing patients who are well into their 80s very happily using smartphone apps. That's obviously not going to be everyone, but I think we need to be careful, not just as a blanket to assume that certain groups are or aren't going to engage. What we need to be driven by is a really robust evaluation framework. We need to make sure that we involve patients at all different steps, including the design of some of these portals and interventions. And I also think what's going to be a really big benefit is actually trying to, similar to the points made earlier, reduce the number of interfaces that someone has to sign into. So as a clinician, it frustrates me to no end when I've got to sign into a different EPR and then a different image system and then a different outpatient thing. Can we imagine what that must feel like for patients if they have to go to multiple things? Which means, in my mind, one of two things needs to happen. We either need to move to supporting and building solutions that deal with an entire breadth of a patient's journey, so agnosticism, or a system where we've got real meaningful interoperability. So all the data can be pulled and pushed into the relevant EHRs. You can link in with various apps. There's no break between primary care and secondary care. And I actually think if you do that, there are huge benefits. So a lot of the work that we're now doing, particularly in collaboration with, in primary care, in collaboration with the MyGP app, starting to realize that actually, if you go to this model that is a bit more predictive and proactive, we can now start to potentially identify patients who might benefit from certain interventions, certain educations. Maybe there's a trial going on that they would benefit from. We can actually bring all of that together and signpost those patients to services or interventions that they would really benefit from. And the evidence we've got so far is actually that's been really, really welcomed. If you give people stuff that's relevant to them and that helps them in their care journey, I think that's always going to be welcomed. That needs a lot of work. It needs a lot of collaboration, but I think it's really where we need to go.
Thank you. Simon, I'm going to ask you to give me a 2-minute update on that question.
Apologies, Simon, I had to mute you remotely a second ago. Sorry about that.
That's all right. My view is very well aligned with Arash, actually, and you know, my thoughts are exactly the same. You know, first of all, I would like to say my 84-year-old mother uses her technology incredibly well. Has had an amazingly life-transforming knee replacement by the NHS, and so I totally agree with that first point, that we shouldn't underestimate our community at all. Actually, we should pull people in and their families into this digital environment, and we will be amazed by it. I think by the response. So look, I think broadly, I'd just say I agree with Arash. I think we've got an opportunity to support that end-to-end pathway, and I think health technology as a whole is ready to step in and do that. So yeah, no, I wouldn't add anything.
Thank you. And Sunil, your thoughts in terms of getting clinicians engaged in technology?
I think Arash and Simon have mentioned the key is technology, and also having an open mind. You know, like not to worry that, and try some of these issues. We face the same issue that some of my colleagues were worried: are we going to be monitoring these patients well? Who's going to engage? But once you show that it works, 100% are on board. So I think it's collaboration and just alleviating some of these anxieties. And just to finish off, there is some, like patients are willing to share some of their information with us. Like there is that there's a program which looks at dementia patients. When they are being monitored at home, they have a pressure monitoring at home, and if they fall down, then that alerts someone, so they can easily come and help them out. So if we start thinking of it that way, that we can help people out, then opportunities open up.
Thank you very, very much, Sunil. Okay, Jenny, you're just coming in, so just with a couple of minutes to go, could I ask maybe Arash the question about how do we control cybersecurity risks?
I think that comes down to so firstly, I should say I come from this very much as a clinician, or as a kind of a technical expert. I think what is really important is to have those kind of robust checks and processes, the certifications. The NHS actually does quite well on that. The various tenders and things I've gone through do make sure that you can go through all those hoops. I think that goes first and foremost. I think actually the next bit is less about the kind of the security, but actually trying to change the conversation with patients about their data and making them, be more of an owner of their data, because actually this is slightly changing the way that we are doing care. And I think it's an important conversation for us to be having. Traditionally at the moment, it's very much quite transactional in healthcare. We're now going to be potentially moving to a model where patients will regularly submit bits of information. Some clinicians are going to see that. It may well be that they'll then use that to enroll themselves into a trial. So I think what's really important is for us to have quite an honest, transparent conversation with patients about what that data is, who owns it, who's there. And I think that can only be a good thing.
Thank you very, very much. And I think now with patient portals coming in, actually that ability to get data and results back out to patients really quickly cannot be anything but a good thing. It's patients' data, they actually own it, it is not our data. So that's really important. So I'm going to thank my three fantastic speakers, Simon, Sunil and Arash, for a really fantastic conversation. What I think I've learned is we need to move to a system where, just like every now needs to have the same USB port and power port, we need to start developing digital technology that does what we need it to do. But the most important thing is that as clinicians, we need to be open to be using it. And I think we need to now be curious and inquisitive to say, how do we do what we do every day better for the benefit of patients, because that's why we are there, but for the benefit of each other, because there is no doubt that everyone is exhausted. And by saving time, by becoming efficient, actually we start to respect our staff who work in the NHS to provide the care that we need to our patients. So I'm very, very much looking to the after webinar conversations, because they are always very important. We have emails in the chat group. Please do feel free to get in touch. But once again, I'm going to thank my speakers for a fantastic conversation today. Take care, everyone, and look forward to meeting you again.
Thank you.
Thank you all for attending. Thank you to the speakers. We're going to go now. Thank you very much.
Thank you. Bye-bye.